Okay, good afternoon everybody and welcome. I'm Peter Hudson, I'm the Director of the Centre for Palliative Care, and it's great to see so much interest in this, our inaugural Centre for Palliative Care hot topic. So a warm welcome to you all. Before we get underway, I'd like to acknowledge the traditional owners of this land, the Wurundjeri Nation, and pay respect to their elders and families. As I said at the outset, this is our first Centre for Palliative Care hot topic forum. We plan on having 2 more this year and then hopefully on an ongoing basis. The intent is that these are opportunities for open discussion on matters that are currently topical to palliative care provision, and I imagine usually topics that are somewhat controversial. So, to introduce Associate Professor Mark Boughey, who many of you in this room know, but it's interesting looking at Mark's biography, and I've worked with Mark closely now for a number of years, and you find out some things that you perhaps were meant to know and didn't know. But to summarise, Mark is currently the Director of Palliative Medicine here at St Vincent's and Co-Deputy Director of the Centre for Palliative Care. He's the immediate past President for the Royal Australian College of Physicians Chapter of Palliative Medicine and current President of the Australian and New Zealand Society of Palliative Medicine. Internationally, he's been involved as a mentor to emerging palliative medicine leaders in less developed countries through the Open Society of the United States National Cancer Institute, which is sponsored by the International Palliative Medicine Leadership Development Initiative. Mark has been a leading proponent and director of the End-of-Life Care Pathways program, which is auspiced by our Centre for Palliative Care. So he's perfectly placed to present this afternoon's hot topic entitled Care at the End of Life, Has the Liverpool Care Pathway Lost Its Way? Please make Mark feel welcome.
Thank you Peter for the introduction, and again thank you for so many of you coming today to listen to this presentation. It's great to see so many colleagues and people who work in the field, but obviously there are people that work across other areas of health as well today. I thought actually I'd start off before launching in, because this is our hot topic. I thought I'd just ask the question of the audience: does anyone know the Scoville rating system or rating scale? So Scoville is a system that was created, I think in 1910, that was to really try and rate the heat that was generated by chilies when they were given to you. So we all go to the supermarket and we buy different chilies and we have different preferences. Well, it's instructive to our discussion today, because the way they do it, they extract a certain amount of chili from each, a capsinogen from each product, whatever the chili is or the compound, using a certain amount of alcohol. And they have 5 people who stick one taste onto their tongue and decide the heat scale that's going to be generated by that. So there's a complete individual variability, there's a huge amount of difference due to human subjectivity, but there's about a 30 to 50% variance in the scale ratings. So somehow the chili scale rating that we taste chilies with has a very imprecise, but all working in the same direction kind of approach. And just to give you an idea, bell pepper is 0, a jalapeno pepper, which is one you might walk into the supermarket and take home tonight, is about 1,000. Tabasco and cayenne pepper is about 30,000, and the spray the police use is about 16 million. So just to give you an idea, so you've got wide variation. So if you learn nothing else tonight, you'll now go to the books and look about Scoville rating system. Today is really a chance to do some sharing of information and opinion, and I think really a little bit didactic in the sense of the presentation, but then obviously questions and discussion afterwards. Really it's to focus on the concerns and the context that we see ourselves in, not just for Liverpool in terms of the Liverpool Care Pathway, but for any end-of-life program where there is a program to try and encourage consistency and a common approach to care of the dying. I think it's instructive that there are lessons to be learnt, and there have been lessons to be learnt along the way, and there are obviously implications for the steps forward for all of us that are focusing on end-of-life care, and it's particularly relevant at the moment, not only with the state government's release of the advanced care planning strategy at the weekend, but also the consensus document that the Safety Commission is circulating at the moment, and people are making comment about what is good quality end-of-life care into the future, and how should that shape up possibly and potentially standards that would be built into the healthcare system. People may know Balfour Mount, and in Balfour Mount, in the Life Before Death series of DVD and podcasts, asks the question of all of us to the audience, how would you want to die, or how will you die? And I think it's imperative that when we think about that process, he can paint very, very broad brushstrokes. We can paint broad brushstrokes of when things go wrong, of isolation, of inconsidered symptom control, delays in conversations, all the things that we struggle with in palliative care, particularly in specialist palliative care, to see day in, day out as we walk towards patients and families who are moving towards dying and at the bedside. He also, on the other hand, can paint a picture where there is connection and discussion and support, and we can read into this what we feel, whatever our specialist field is, medicine, nursing, allied health, psychology, whatever domain, we can read into things. We know as specialists in our field, people who work in palliative care, what this means at the bedside for the clinician working in palliative care. So you can see that there's a huge gap between the translation of broad brushstroke approaches to what actually happens in a consistent way at the bedside. Similarly, as I've already mentioned, the new national consensus statement that's doing the rounds at the moment, it often pulls out in the definitions that some of the aspects of care could be defined in the realm of palliative care, which these do. So we're narrowing it down from broad brushstrokes to ones that really are more specific to death and dying, that we are focusing on some of the issues around comfort and dignity and support for patients and families. And we're looking at not only the immediate dying phase, but those last year or two of life as disease and disability and all the concerns and illnesses that come together to bring people towards facing end-of-life care. And the notion that all clinicians should be able to approach this particular issue and problem with a consistent kind of caring approach. Now, we know this is huge pie-in-the-sky sort of stuff. We know the variability. We know the variability across different specialties, different generalist domains, interest, locations, private, public, community, home. We know the variation is there, but idealistically, we're all aiming for that. But how do you translate idealism? How do you translate notions and value statements to bedside care? In many ways, we focus on patients as clinical events, sentinel events in their particular journey, and I'm thinking obviously in my work within maybe acute care hospitals and palliative care units, but certainly in the community in any domain when things are happening. But for our particular territory in that last year or two of life, we might be focusing on areas where we've got the patient who has progressive disease, we have a deteriorating kind of phases of that journey, but then we also have the phase where we need to focus on the increasing recognition of dying. Into that mix, and I could have covered this page with documents of standards and care planning and processes that have been built into our healthcare system to try and prompt people to somehow be aware and to be able to enact planning around certain sentinel or clinical events in people's journey. And some are very specific in terms of resuscitation orders and active resuscitation, not for resuscitation, those sorts of issues. Some are more broad and more generalist and more kind of generating a discussion at the bedside on events such as advanced care planning. And then the standards that come into play to try and regulate the way in which organisations, may not so much in the process but also in the outcomes to that success. The difficulty though lies in what we actually do then at the bedside. What do we do to bring clinical practice and care to the bedside beyond just the individual in the way we teach and train and bring people who are moving into the system to become the new leaders and experts and clinicians of the future? And how do we make meaningful and appropriate decision making at that time? How do we as clinicians do that? We can all step back a few years, some of us a few more years, to know when we first started off in working in health, how different our approach and our technique and our way of communicating is now to when we're stepping at the coalface now. But how would it have been if we had people to mentor and teach us maybe ways to approach situations and problems in this domain? So today, for those of you who maybe aren't as familiar with end-of-life care planning and pathways, is we're focusing on that phase of recognition of dying and what is it that has potentially been put into play to try and give a sense of consistency of care, to give us the prompts to genuine bedside approach care communication that encompasses not only the aims of palliative care but helps to bring clinicians to that consistency that we're hoping to achieve. We all know the story very well of deaths in Australia. We know that in Victoria about 36,000 deaths per annum. We know that over 50%, and it's interesting how consistent that is in developed countries. If you look at UK and places like that, around 50% will die as an admitted patient in a hospital, whereas just under 50% away from hospital settings. And even though there's an increase in admitted patients' connections with palliative care, and this is some of the latest data that's been collected by the AIHW, is that still, and again there are problems, if people have read this particular report, there are problems in tackling trying to get what is an admitted palliative care patient registered. But we still see that dying isn't really the realm of palliative care in terms of day-to-day contact. We're a niche grouping, those of us that work in specialist palliative care. A lot of people die away from the clinicians that have had training and development of expertise in this particular area. So if we come back to this whole idea and notion of looking at what is it we can bring to the bedside, what can we do to translate ideal visions of care, of standards and planning, what can we do to try and bring that to the bedside? Now, as you know, to bring it down a little bit, we all work with standards, and palliative care and end-of-life care isn't a unique area of healthcare that doesn't work by standards. And people that work in the field would know these well from our Palliative Care Australia national standards, which is, in many ways has generated huge change amongst healthcare organisations in terms of the self-assessment process and cycles. A document I particularly like is the General Medical Council of the UK, which pulls together a lot of these elements and puts them in a place where things like advanced care planning, resuscitation, end-of-life care processes and practices can be seen in context of the whole of health care of patients and families. More recently, as mentioned, the National Consensus Standards, and even more recently is the ANSPAM, the Australian New Zealand Society of Palliative Medicine's position statement on what is quality end-of-life care. And it's worthwhile then just to reflect on maybe the ANSPAM one, a little bit of self-promotion here, but anyway. But really just to say what they've done to try and say is to bring about the 5 domains which they see as essential elements in quality and safety and appropriate clinical care at the end of life. And these are no surprise to you. It's not a new revelation that these are there, but it's really just to say that this is what they consider the 5 domains. As I say, it's bread and butter to palliative care. But what they also emphasise is that maybe there needs to be a timely recognition of the dying phase, and that maybe terminal phase plans need to be there to really make sure, because the patients that are dying day in, day out aren't always connecting to specialist palliative care, that maybe we do need to have people adequately managed and supported for not only the patient and their family, but other loved ones and carers as well. So again, we've come to a point where we do have standards, we do have self-assessments, we do have processes developing to translate things towards the bed, towards bedside care. As I said, many years ago, I think it's back in the early 1994, that it could have felt like the 1940s most probably, for John Ellis and co. But the LCP really generated out of people asking that particular question, how can we bring a sort of sense of consistency and prompting that's beyond just a tick box that sits in a cupboard somewhere. We all know in palliative care the rollout of palliative care into aged care, the first sort of generation of that, and how things just sat on the shelf without any systematised implementation process. So really it was generated out of local need, and we know around the world, we know in Australia, that local need has generated the development of end-of-life care plans in a number of settings. Hospitals, acute care community, different organisations, different groupings have come together to develop their own planning processes. What is important, I think, though, is that this really, it must have been a good idea because it caught on pretty quickly. You know, it's not so sort of politically correct to say this seemed to be the second most exciting thing that ever came out of Liverpool besides the Beatles. But really, and that will come back to bite you at the end of my talk. So, but it is interesting that it's an idea that seemed to catch on. It seemed to make sense, and as you will see, it didn't take long before the NHS was buying into this particular process, and certainly auditing nationally in the UK, the auditing of death and dying in 07, 09 and 11. Obviously the idea caught fire, the idea has spread to about 21 other countries at the moment, and as you know there's been different levels of engagement around the globe, particularly in more developed, but certainly moving into less well developed countries and worlds. And often it was driven by a personal desire to improve for a hospital in a more general way, or in a community setting, or in a residential aged care setting, the specifics of what needs to be brought together. If you've really missed the boat in this journey and somebody's dying, then what is it that still needs to be done and is necessary to impart sort of care at the end of life? We all know, though, that in 2009 through to sort of mid-11, that there was a sort of generating media focus in the UK on issues to do with death and dying, issues to do with the way in which people were maybe not dying in appropriate sorts of ways. And there was certainly a connecting of end-of-life care plans and pathways to the issues and problems and concerns of the health system within the UK, but also then the dying phase of people's care. And certainly the connection to Liverpool and to the pathway was obvious because it was already a national scheme that was well supported by the NHS. And it's not news to people who've been following this that as a response, the government set up an inquiry into the pathway, which has become known as the Neuberger Report, who was the chair. She was the chair of the reporting committee. What I think is important, though, and this is, you know, the more you step into this realm and think about this, and this isn't just pertinent to the Liverpool Care Pathway, but what was implicit in the development of it was the need to look at some sort of methodology to help drive the quality of the dying. And certainly the inclusion of a sort of the integrated pathway methodology, I think, was critical to its initial development. As people may know, it's a way of looking at complex variabilities. It's an intervention, complex intervention. As we know, if you think about randomised controlled trials that often vary one variability in a drug trial, you may find in this situation that there's a number of things that are varied between different groups. It's a complex intervention. We have to remember that in terms of this sorts of work. But there's consensus around decision-making and organisation of the care and processes that come into a well-defined group of patients over a defined period of time. And for those of you across the healthcare spectrum, we well know that pathways are a part of healthcare that is increasingly generating discussion at the moment. There's certainly talking, I mean, certainly across different healthcare sectors, there are different focuses on pathways to try and sustain and make sure there is a consistency of care brought to not only the bedside, the operating table, the processes behind setting things up in terms of healthcare. It's not just end-of-life care has suddenly taken this to heart. It's a common part of healthcare practice. And certainly if you're looking at the review processes that have come to light since the Neuberger report, certainly there's some moderate but indirect, often very much qualitatively focused, that suggest pathways for managing the dying phase may improve care but aren't being implemented adequately. And that's no surprise if you've read the report to come from that. But what is important is, and this is the difficulty, how can you say that the methodology that works for one group of illnesses or problems or concerns is going to work in another area of problems and concerns? But there is sort of evidence to suggest that the pathways around end-of-life care may be an important methodology to consider. Interestingly, for those that have read the recently published Massimo Constantini article, and again, it depends on interpretation, which I'll come back to in a little while, but there is certainly evidence that in terms specifically of his cluster randomised trial, is that there was no specific harms, and there were some benefits around the particular, maybe holistic approach to care in that process. But what I think it underpins is that a methodology to try and contextualise development of a systematic approach to dying at the bedside was always core to the particular development. So in understanding that pathway process, I think in looking at the essential characteristics, and we'll just run through this fairly quickly, it's then bringing it down. So what I'm trying to do is to show how it's coming down to the bedside. This is the whole idea. It's to try and take it from that broad brush strokes, the kind of painting, down to what's actually happening at the bedside for clinicians and how they can actually kind of learn and understand on the job. And from this comes the 10 principles and characteristics that are important. From this we have then a sense of compliance, and this is really the focus on the introduction, education and training and implementation processes. And then we come down to what's actually happening at the bedside in terms of clinical care and documentation. Now again, this isn't breaking news to anybody that's using pathway sort of processes and integrated care planning type processes at the bedside. It's not just to the Liverpool process, but it's to anyone that's looking at these sorts of processes in their healthcare facility. And again, it is the ability and the variability and the way in which things are then implemented that most probably starts to highlight where some of the concerns and issues can come from. If you think of those poor five guys who are sitting there trying to taste all the different pepper sprays and capsinogen levels, you can understand how it doesn't take long, especially when there's a bit of pain and suffering going along in these processes, to start to introduce variability to any of these steps in actually bringing care to the bedside. If we quickly look at the integrated pathway characteristics around end-of-life care, we see the things that we're trying to look at, the goals and best evidence and practice, facilitating communication, not only amongst the team, but also obviously patients and families, the coordination, the use of the multidisciplinary process, particularly around the recognition of dying, and again, the documentation, evaluation and so forth. And again, this isn't new to those of us that have been working in this space for a while. In terms of the core principles specifically tailored to the Liverpool Care Pathway, which are important to just recall, and I'll come back to these in a while, is some of the very specifics that really, if somebody is recognised as dying, these are the things that should be brought into play at the bedside. So again, we're coming right down to the bedside level. And you recognise that these are things that are often seen as common palliative care kind of practice, working towards end-of-life care, recognition of dying, giving it opportunity and space for a natural death, hopefully, or a comfortable symptom-controlled dying process with regular connection and contact with the family and the people around them. What was important for the Liverpool process and any quality activity is that there are quality assurance activities that were brought into play to make sure that this was brought into the realm of sustainability. And if you could think of an area in your own experience of healthcare, whether it's big level organisational reviews and the introduction of new standards, if you can think of variability where things can really go astray, this is most probably one area that it seems endless that problems and concerns can develop if education and training isn't ongoing. We're not just doing all this for our organisational review every 2 years or 4 years. We're doing it to try and bring consistency of care to the bedside. So it begs the question, with all these robust processes in place, where do things go wrong? And I think for the UK, particularly for Marie Curie, particularly for John Ellis and maybe others, it did feel like free fall, I think, for them. Interestingly, when we do go around the world and talk to international colleagues, what has happened in the UK hasn't seemingly been replicated around the globe in any of the other jurisdictions where these concerns are happening. The recognition that the media generation of these issues comes from an organisation that does have huge global reach is most probably the thing that's giving some people concern that maybe it's not going to be long before these sorts of concerns may be brought to bear elsewhere in the world. But there are things that are different, and we'll talk about those in a minute. So what did go wrong? You can most probably see, if I was to ask you in the audience, where the problems could crop up. We all know from our own healthcare experience that well-intentioned documentation, well-intentioned processes are they're processes, but you need the intent, you need the ongoing concern, training, education, implementation as generations move through the healthcare system. You need the public to understand that maybe this is part of why we're trying to connect with dying, to improve dying. It's not just something that's implemented as a document to say you are now dying sort of thing. So we know this well. And the headlines may not be something that you're familiar with, but if anything, the people in the UK could definitely quote these headlines, particularly with the Marie Curie group. And again, if you look at interpretation, it's interesting to see how this has generated great concern amongst a lot of people, made people in the UK very nervous and anxious. What's even important as I come to interpretation, if you look at the interpretation of Massimo Constantini's article, you can see that they've taken the same results but put a sort of maybe the half very empty look at it rather than bubbling over with joy and some positivity for the newspaper. So I think just in summary around some of the events of the report, and again people may have seen this, is that there are 44 recommendations, and I don't want to sort of quote through all of them, but really it recognised, and this is the interesting thing, it actually recognised that possibly that the principles that underpinned it were necessarily good. And again, I don't just think for Liverpool Care Pathway, but certainly the principles of dying for many of the end-of-life care pathways could take a very positive look at this. And again, I think the important part, which I've already mentioned, is that it was recognised that it actually did provide good care when implemented properly. And there's a very big line that should be drawn under that in texture and crayon saying when implemented properly. And we all know, I think, in retrospect, maybe pathway seemed a good word because it's reflecting the methodology, but really socially and in the media and in common language, what we see as a methodology in a healthcare setting is seen as a kind of treadmill to problems and distress and so forth and death. The one that really caught them by surprise was because in the draft that they saw, this wasn't mentioned, but suddenly appeared, and this is where the politics comes into play in reports that I guess come from government at times, is that between the draft and the final document, some very key recommendations came to really say that, well, let's say no to care plans around the dying phase. Let's look at individual. Let's think about an individual focus rather than a sort of a global. And because of the UK is very LCP centric, the LCP obviously was the one that has taken the brunt of that particular concern. Obviously, the tying and targets of funding to the LCP, again in retrospect, and it's a big contrast and difference to the Australian and any other settings around the world, but certainly in the Victorian setting, is a significant. I try to tell younger doctors to remind people when we used to get paid to suggest cremation as a way of solving some problem in the world. I'm not quite sure what that problem ever was, but colloquially we used to call it ash cash. And we got paid to talk families into, we couldn't talk them into having postmortems, but we could talk them into having cremations. So how times have changed. But maybe they haven't changed. Maybe it was a good idea at the time that in evolutionary terms found a point where it just seemed a bit ridiculous. You can just see the conflicts of interest, can't you, in palliative care, anyway, that could be one of them. But I think very genuinely concerns around this whole, the process stuff, the outcome is death, and you can evaluate some of that, but really around the processes of communication to the public, communications to the individual families and people, the variability across healthcare sectors and settings. What wasn't apparent as much to myself and to others from the international setting was the difficulties of the accreditation process in the UK at looking at these. And then obviously the sort of education. And there's a whole lot of things we could go into, but just really focusing on things that are global, that really have been highlighted by this report, but are global, and not just global to end-of-life care plans, but to any implementation of a new policy, pathway, way of working. So advanced care planning, I think, it's a cautionary tale, I think, for the rest of advanced care planning. It's a cautionary tale that we need to have the ability to implement and educate and train in a very systematic way within healthcare organisations and services. So again, if we're going to say that this is where the problem area is, what does that mean? What does that mean for clinical practice? What is the response? If we're being told that we've got these global kind of big picture ideas and that we want to bring to the bedside and maintain and train and educate and make sure it becomes a consistent approach to care, what do we do if we are now told that the methodology that we've been using to try and create that situation is now seen to be faulty, and in the public eye is seen to be deleterious to those sorts of processes? So in amongst all this confusion and difficulty, John Ellis decided, we were doing some work in San Diego and with the international development work, and he and Carl from Sweden and Lucas from Germany and Holly, people who've been over to San Diego, which was the Palliative Medicine Institute there, were all trying their hand at surfing as a bit of a relax, I think, underneath the media pressure. But I think, you know, John Ellis really summed it up quite nicely, and I think in many ways this nervousness and this sort of block in the river, it was a historic opportunity really to focus on end-of-life care issues, but also not just the dying, but it was the trajectory, the problems backwards from this, the problems of what was happening in this sort of space before coming to the dying phase. It wasn't just the healthcare issues of the dying, it was the healthcare issues of caring for people with a deteriorating life-limiting illness within the UK setting that was really being put under the focus and under the pump. And really, I think what he saw was his responsibility was to, or not just his, but their organisations, was to all say, yes, we have taken the brunt of this, and it was a huge blow. But let's look at this as an important way of now having to try and work with the organisations to re-establish confidence in care of the dying in the UK setting. And I think realistically, so what they've done over that time was to bring together the international partners of the reference group to talk about these issues and to recognise that need for ongoing research and development. But it's around some key areas in terms of the area of looking after people. It's the recognition of dying process and that interconnection between deterioration and dying, and how does that become something that generalists and physicians and surgeons can work with that is seen as ethically sound, not as sort of reductionist or ethically unsound. So the continued need for treatment that might provide hope is unrealistic when the context is that you've actually got a dying patient in front of you. You need to contextualise that dying is occurring. How do you work with the ethical, cultural, faith-driven issues around hydration and nutrition and how that sits? And those issues around sedation and the need to... So very key issues that they saw as really where some of the issues were really coming to light. And it wasn't just around the pathway use, it was the general concerns that were brought to bear in the process of moving from a deteriorating patient to a dying patient. Highlighting again that everyone needs to be able to have some ability to be able to care for dying patients, and the training and education needs to be ongoing and continuous and across all domains of healthcare. And that implementation really is an area that needs new bones to it, new legs to it. Beyond what they were doing at the beginning of these sorts of phases of introducing an end-of-life care plan, it needs to have an ongoing. And maybe this is where the national consensus document in Australia is heading, to bring that to bear, to get the carrot and stick, or the stick maybe, to get people to take this seriously. And I think one area where engagement hasn't occurred in a significantly positive way is that social engagement around death and dying. It's often about euthanasia, it's often about issues that maybe are out of our control in the healthcare system and don't really reflect the nitty-gritty for most people when they're facing deterioration and end-of-life care. Even in our own institution here, we had the opportunity for a visiting physician to do a staff survey, and instructively, and this is what's being brought to bear by the organisations from around the world to the collaborative focusing on LCP, is that the utility of something like, for younger people coming into a system, for people who aren't familiar with death and dying in specialist palliative care, as the more experienced you are, the more burdensome the documentation may seem to become. And therefore it seems to undermine. So people are looking for clinical skills and judgment, good judgment, and it becomes something that starts to undermine that process within people's kind of consideration of the way they work with patients and families. So how do you re-steer a document from just being a document to being something that can move across these levels of experience and expertise? How can you take a document that's supposed to facilitate multidisciplinary approaches to one that doesn't just become a document that's driven for nursing? How do you engage people in those sorts of processes? So again, instructive in our own organisation in specialist palliative care to focus on the burdensome of bedside documentation versus bedside care. And the necessity, I mean, of ongoing training, and the spotlight turned on the medical team very clearly in our survey of what we thought we were doing and the reality of what was occurring when it came to actually using the LCP. So it's interesting when you focus on your own healthcare organisation what comes to light, and it's very instructive to the rest of the process. And in many ways, this is what the collaborative now is focusing on. is let's bring the worldwide expertise, the understandings, the concerns, and let's pour it back into the system and try and see what we can work with around an end-of-life care, best care for the dying person sort of process. If your email boxes haven't been filled with different bits and pieces in the last few months after this in palliative care, there's a number of editorials, but there's a couple of very key documents that I think are worth looking at if you haven't looked at them. And certainly Dr. Ruth Parry's rapid evidence briefing paper, I think, is a terrific summary, chopping down the pathway into its various components and looking at various parts and the evidence that would sit to try and say, well, this is most probably a reasonable approach, this is something that's failing, this is something that's not bringing to the table. And again, the quote I brought to bear earlier on certainly is a summary of that work, but I think is a very instructive and a useful one to focus on. In the UK, the National Health has set up the Leadership Alliance. There's a number of key organisations, including General Medical Council, the government, NHS, including Marie Curie, Pathways Association of European Pathways Association. A number of players have brought into this space to now make the recommendations, and people around the world had the opportunity to comment around this and look at the plans of care for the dying people. And again, the initiatives from the Marie Curie Institute. What is interesting and what is hidden in all the context of this is that in many ways there's been quite a backlash. There's a recognition that maybe whatever comes next is really going to kind of be similar to what was happening, maybe. But really, the common principles of good palliative care is what really the LCP was doing. In terms of losing its way, maybe the rapid rise of its popularity without the systems being in place to support it, maybe in retrospect, is the thing that really came unstuck. That those things we've talked about already didn't happen in a way that should have allowed a ground-up kind of approach rather than an introduction of something that wasn't adopted and accepted and contained and controlled. It's difficult to know. So the backlash has been is, you know, politics can have a place, but politics can be a little bit tricky and dangerous. And not just in politics, that same paper decided that, so it's gone from the let's be negative to, well, we're negative, but this is in a more positive way for us guys. But the interesting thing is this one, which was another one that came out a little while. And I make reference to the Beatles because this is just how classic papers go, is that they've got a picture of Paul McCartney under this, and I've got no idea, when you actually read the article, there's no reference to Paul McCartney and his wife whatsoever. So either they've just associated Liverpool and maybe they're talking about the old days. He looks a little frail and fragile there, but so I'm just thinking maybe all pathways do actually lead back to Liverpool. But so just briefly, just to really say where from here, and again, even though I'm focusing on my work with the International Collaborative and around Liverpool, I think it's instructive for all of us who are working in this space and utilising in aged care facilities and other services and organisations. I bring back to the question of how do we take our hands away and say, look, we've learnt our lesson, let's let the ship find its own way. Let's I don't want to pick on Scotland, but just to show you what in some jurisdictions has been the approach, it's very much a hands-off approach. It's giving guidance to say that we can give you the principles and the thinking, but you've got to inform your own thinking. You've got to decide for yourself what that patient-centred care and the need of the individual is going to be for. If we chisel down a little bit, it kind of gives you these kind of broad global aspects that you just have to adhere to key principles, which I'm sure you've all had time to read. When somebody's getting respiratory distress at the bedside, you know exactly what to do. The key principles will come straight to your mind. You really know that you can take into account uncertainty. You can ask a grad nurse or a junior doctor to be able to tackle uncertainty. So you know that all staff will be able to, from the top surgeon down, will be able to communicate clearly and sensitively to to the patients and families, particularly if they're also on the panel for tasting the chilies at the same time. You can imagine how clear and consistent communication could be with a few chili stings in your mouth. But I'm just, in a way, trying to show that, so again, this toss turn between how much guidance do you give, how much rigidity do you put to the care versus how much do you let go. And this is just an example which came out recently to say this is an approach of NHS in Scotland. Just to bring it home, and again, this isn't new, but it's really to say that the Victorian government's approach through the end-of-life care coordinating program is to really say, look, okay, there are implications for what your service is doing and the way that we're looking at and adapting end-of-life care pathways and plans and the implementation process. And really it's saying, look, we're saying it's a good methodology, let's keep doing what we're doing. Maybe if you're introducing and thinking about introducing, let's wait as the interim period, get your processes in place. And to do that, in Victoria, the end-of-life coordinating program is strengthening the program manager's position, and our new program manager has just stepped into the role, Donna Caro. We're looking at creating a sort of global nurse educator position to help not directly educate, but to educate people to be able to be better educating. We're looking at developing a risk framework which brings together a whole lot of these process issues that organisations and people need to be mindful of in terms of the standards and quality. We are part of a national dialogue in Australia and New Zealand. And interestingly, just in the last couple of days, I've fortunately been asked to become the Australian member to the ongoing international collaborative executive to help bring the voice of this part of the world to the table. So there's a lot of stuff that's happening in this space, which I don't think will just benefit whatever is evolving from the Liverpool perspective, but will help to enhance not only the standards development within Australia, but also then the impact to healthcare services for anyone that's considering the planning around end-of-life care. So just to give you a few key, I will stop, is to really say that there's this 12-month interim period to bring the methodology to bear. For those of you who like diagrams, which I do myself, it's really to say that we don't just want to have a best model, we want to try and have a best implementation process as well. And the people from other countries, particularly in the UK, are looking to us in Australia around the implementation process. They see our national accreditation system as a very strong embedded processes. So even though we whinge and groan and moan and hate those organisational reviews and getting those boards up and being able to quote fire drills till they come home, they are looking to us to be a leader in this particular area of that process. And so if I was to come full circle and talk about has the care pathway lost its way, I don't necessarily think it lost its way in a sense. I think it really was forced to take a pause. There are many pathways that could be taken. There are many. I mean, it's a nice analogy. The sort of Will Cairns used the braided river, the story, the Bobby Burns poem. But really, I think it's a necessary pause in the evolution of focusing on end-of-life care and dying. It most probably lost its way because its success became everyone's need, everyone's desire to take what they had developed and somehow define it, refine it, distill it for their own organisations and countries and places, really became the issue and the problem. So if we come back to the patient at the bedside, and how do we understand that the experience of others well cared for is something that we really should cherish in our healthcare system? It shouldn't be something that's difficult, that shouldn't be tackled, that shouldn't be stepped into that space. How can we make the person who wants to run away from this part of their responsibilities in healthcare to understand that it is something that we should nurture and cherish? We should see it as a engaging and touching and important part of the system. We've tried to focus on where the change is going to occur, and I think it is in implementation education. It is in maybe the way documentation, and some organisations have done this already, very cleverly have taken that approach. And so into the future, when you then decide that maybe healthcare isn't for you, you want to take up tasting chilies and decide that maybe that's where your journey in life should take you, think of the Scoville rating scale, but maybe take some time today and into the future to contribute to the ongoing discussion about end-of-life care planning and pathways. So, thank you.
Thanks very much, Mark. Now over to you. Comments and questions, please.
Jane Rogers from the Grampians Regional Palliative Care Team. We piloted the LCP across 2 acute sites, 1 subacute site and an inpatient palliative care ward. And the success in the inpatient palliative care ward was outstanding. Feedback from the nurse unit manager was that it ticked all the boxes for them. They didn't find it burdensome at all. It was multidisciplinary. It gave them a framework, and even after the pilot, they're still using it for every death. So our experience has probably been a bit different from what you've just reported, in that our inpatient palliative care ward is now helping us to drive the rollout of an end-of-life care plan, whatever we're going to now call it. And their experiences have been quite positive.
Thank you for that. I think it's interesting when you talk to a number of colleagues, there is a sense of burdensome around some of the prescriptive elements, and I think it's recognised that at the bedside, and it's interesting, it's kind of seen as an Anglo versus European discussion in many ways, but I think it's something that's universal, is that the sort of derivative sort of approach has caused some sense of burdensome for some people, and I think that is something that they're seriously looking at, is how can you have a sort of a fixed components, but how can you allow variability to come into play? Because we often, process is one thing and outcomes is another thing, and how do we make that sort of balance? And it's one of our colleagues here at the last meeting, Melanie Benson, said, you know, it's just like a home loan. You want your fixed bit and you want your variable bit, and then we'll all be happy. Because I think, I take your point, we have many stories where there's been this shift where people have seen the benefits of planning and having consistency. Now how that then translates, and the fact that they then are able to articulate that to others, is a very important part. So I think that's it's a good lesson to learn for any end-of-life care planning. Thank you. Kevin.
Kevin McGovern from the Chisholm Health Ethics Centre. Mark, thank you for your presentation. There seemed to be a lot of fear and anxiety about the LCP in the United Kingdom. Has there been anything of that here in Australia?
Thanks, Kevin. As I mentioned early on, that really hasn't percolated up. We were expecting initially at the end-of-life coordinating centre, we were expecting a bit of a flurry. I think we had one phone call. But universally, I think most clinicians, unless people in the room, we really haven't had individual patients or families raise it as an area of concern at the bedside. I think it hasn't seemingly produced a lot of anxiety amongst staff. I think it's more that if we're looking at organisational change, that, you know, some of the issues have come to bear in terms of the issues in the UK and how we translate that to ongoing change. But I really, and I don't think I'm being naive to it in Australia, I've talked to a lot of colleagues and people, but it really hasn't been something that's taken any sort of media exposure yet. So I don't know if that's just that people don't read UK papers or follow what the Beatles are getting up to, but
Hi, I'm Sonia Fullerton from Peter Mac. Is this working?
yes.
Oh, good. I'm a big fan of the LCP. My team and I probably looked after about 2,000 patients on the LCP, and as you say, I haven't had any negative feedback. And if I have, I've explained it in terms of differences in implementation between the NHS and Australia. But my question relates to the press release on the weekend from the Minister for Health. I had the dubious honour of reading 112 pages last night about the strategy for advanced care planning implementation in Victoria. And it struck me that there are a number of similarities between that strategy and the strategy that we've seen that didn't work in the UK, including financial incentives, prescriptive that health services must adopt it. And I'm also a huge fan of advanced care planning, but I wondered about your thoughts about lessons for the implementation of the Victorian advanced care planning strategy in what we've been discussing today.
Yeah. I think, thanks Sonia. Look, I agree. I think, again, towards the beginning I talked about cautionary tales, I think, for the broader healthcare sector, and certainly cautionary tales around advanced care planning. My understanding in the sort of Victorian setting is it's very much an organisational ground-up kind of approach to developing and implementing, and that has its frustrations because we don't get the dollars kind of chunked at us to implement. I think there'll be some implementation projects and pilots to try and bring it into a healthcare setting, but I suspect tying funding to the actual, I mean, there'll be some statistical, and there already is in the VAED, data collecting mechanisms to understand substitute decision makers and advanced care plans, but I wonder if that connection really will be made. It most probably is something that maybe it's inadvertently read into the document. I'm sitting with Barbara sitting right behind you from on the committee that wrote the document, so I don't know if she wants to further add to that, but it may just be useful from somebody who's actually developed it.
Certainly wasn't my understanding that there was going to be a direct link to funding. I know that was said in one of the
Press release. Yeah, it was,
But my understanding is that this is advanced care planning is never going to be compulsory. It's having systems in place to make it available should patients want to do advanced care planning, and having systems to make sure that we record and make those available and use them. But the driver, I think, will be accreditation, not a funding model.
Yeah.
So I haven't sort of anticipated that same thing. And I think there are cautions about, I think bad advanced care planning is worse than none.
Yeah.
And I think there's always that worry that if you do have a fund, a monetary value attached, you will get lots of bad advanced care plans. And advanced care planning is for patients, it's not for us.
Yeah, and that's, if you think that's, as you've just spoken of, Barbara, that's the downfall, in a sense, the lost path of the Liverpool component. It's bad implementation, bad utilisation of what is most very useful tool. And if you think of the variability focusing on the dying phase versus the variability around the whole health system to advanced care planning, you can just see how wide is a cautionary tale, I think, for us.
Thanks very much. Probably got time for one more comment or question.
It's a comment. I don't think we should be tied up with funding. I mean, I think we should be saying, which quite correctly, the funding is not actually there it's for education and training and ongoing education, and that seems a lot lost somewhere.
Thanks, Kate.
One more last burning comment or question. One at the back. It'll be the final comment. Thanks. Leroy.
Leroy from Eastern Health and Monash Health. Francis Peabody said in 1926 in a lecture to the Harvard medical students that the secret of the care of the patient is in caring for the patient. And I think that although people have said that there are great examples of care with end-of-life pathways, I think you see lots of lots of patients and families who the care is substandard from what we would expect. I think some of the documentation isn't filled in as it probably should be, and that's our job as clinicians to educate as we see those things happening. But like Kate said, the education, if you look at undergraduate education for generalists to provide end-of-life care, it's not as it should be. I think it's a big problem that we have to sort of get over into the future, because how we're going to be looked viewed by other people in terms of delivering this care is going to be based on that.
Thanks, Leroy. I would agree. I always think that anyone dying should be considered as complex care. We often think, if you think of complex care, people think of worst case scenarios, difficult pain, conflictual families, but I really think, really to neutralise that and say that we can just generalise it all the time, I think we do ourselves a disservice in forgetting that, it is one of the most important parts of somebody's life is their death, and there is complexity that we may not see, even in the most simple setting. And you're right, it's the bearing of care that's brought to the bedside to the person that is critical, and that's not something that people just adopt because they've read a set of rules. They have to understand that connection, and I think that's why it is complex care, no matter who is dying and in what location.
So on behalf of us all, Mark, thanks again for your comprehensive, somewhat cynical, but I think ultimately optimistic appraisal of the Liverpool Care Pathway, and thank you for being the inaugural speaker for our Hot Topic Forum. So if you could join me in thanking Mark.